Welcome to Pause for the Truth, where you can sit back, relax, and hear an honest dialogue about health, wealth, legal, and social issues. The hosts are Dr. Rogers Kane, family practice physician, and Jocelyn Turner, health education consultant, with co hosts from the Northeast Florida Medical Society and its foundation. Stay tuned for the truth about matters affecting you and your family. We're here to tell you what's really going on and why. Good evening and welcome to Pause for the Truth. I am your co host, Jocelyn Turner. Such a wonderful day in Northeast Florida. It's nice and toasty. As I was walking outside, all I can think is, man, the poor folks who are unhoused and hoping that someone is watching out for them and allowing them to come into one of the shelters in order to get some cool. Joining us this evening, of course, is my co-host, Dr. Rogers Kane. Before we introduce our guests, how you doing this evening, Dr. Kane?
I'm making it.
That sounds like an old person statement, Dr. Kane.
That's just how I feel today. Like an old person.
Well, I'm glad you were able to join us, Dr. Kane, in spite of how you may be feeling today. But luckily, we have some repeat guests. Last week's discussion regarding strokes was so powerful that we thought it was important to bring Drs. Sanders and Green back. How are both of you doing this evening?
I'm doing pretty good today.
Good, good. How about you, Dr. Green?
Fine, thank you. It
Wonderful.
has been a long day, but here I am.
Well, thank you both for the sacrifice of joining us. And we won't take too much of your time, but we know that this is a very important topic. Tonight, we want to focus more on, when someone has a stroke. And by the way, we're talking about, understanding stroke recovery. There are many people who might be listening who unfortunately have either had personal experience either with themselves having a stroke or a loved one having a stroke. And that could be very devastating to the individual as well as to the family. Dr. Sanders, if you will, let's start out by first talking about what is a stroke for just in case someone's joining us who was not here last week.
Sure. And I think also last week there was some discussion about really kind of showing what we're talking about. So I do have a slide up. If Tyrone, you'll put that up for me.
Great.
When we talk about the stroke, I kind of mentioned in the last podcast that there were really three types of strokes, but I did fail to mention kind of a fourth type of episode that I'll add again this week. But when we think about strokes, it can either be an ischemic stroke, which means that there is a blockage in the blood vessel in the brain, as you can see in that top picture. But in some patients, particularly who have excessively high blood pressure, those blood vessels in the brain can actually burst and leak blood into the brain. And that's called an hemorrhagic stroke. When it comes to the ischemic type of stroke, that first one I just talked about, it can either be due to cholesterol plaquing or blood clots that develop within the artery, or it can come from another source, which is most commonly the heart. So in what we call an embolic stroke, the blood clot travels from the heart and it gets lodged inside of the brain. And so when we think about strokes, that's primarily what we think about. But what I failed to mention last visit is there's a different type of episode, which is called a TIA, or a transient ischemic attack. And a TIA is really what we call a stroke warning. Okay. These are neurological symptoms that are consistent with the stroke that come and the symptoms go away. Usually it's within 30 minutes, but that might be an indication that something is going on in the brain that we might need to intervene before you have an actual stroke. Many people will say, I had a mini stroke.
Yeah.
And what I want to clarify is that there is no such thing as a mini stroke. Okay. A TIA, or a transient ischemic attack, is a stroke warning. You didn't have a stroke this time, but this is a warning that you could have another stroke. If you have evidence of a stroke on the brain, whether it's a small stroke or a big stroke, it is considered a major stroke. There are no mini strokes that exist. So it's either a TIA or an active stroke. If you go to the next slide, Tyrone, when it comes to those signs and symptoms of a stroke, I mentioned before, but I want to highlight an acronym that says B FAST. And so what does B FAST means? It means you want to be able to identify the signs of the stroke and then access care very quickly. So B is for balance. E is for blurred vision. Face is for droopiness of the face. They mention arm, but it can also be a leg. So if you have weakness on one side of the body, we want to get some care very quickly. And then speech is slurred speech. And if any of those exist, it could be a TIA or it could be a major stroke, and you want to call 911 very quickly.
And people are so apt, Dr. Sanders, to say, I'm just going to lay down, I'll feel better, right? And unfortunately, that's the wrong thing to do. But even trying, how do you convince someone, though, who thinks that that's a good decision? You know, there are some stubborn people out there. No, I'll be all right. I'm going to tell you what I would do, and tell me if you agree. I would say, okay, and then I would go in another room and call 911.
You can't help that they showed up, right?
Exactly.
Exactly.
Yeah. It's I don't know why people think that it's okay to lie down. And let me ask you another question. Last week we talked about who's most at risk in terms of African Americans being at I won't say greatest, but at great risk. But tell us about who's at risk, and that's for either of you, any of the three of you. Who's most at risk of having a stroke? Crickets.
I'll jump in. I'm happy to do, this is kind of my area. And so really when we think about risk factors for stroke, the primary ones are high blood pressure, particularly if it's uncontrolled, high cholesterol, diabetes, obesity. Those people that have them, regardless of the age they are at highest risk for having a stroke. And I think Dr. Green can highlight and maybe speak more to it, but he highlighted last week atrial fibrillation as well.
Dr. Green?
Yeah, my internet connection just further back and forth from me here.
We can hear you.
I'm in St. Augustine, and we are having a pretty. You might have lost me there a little while. Yeah, there's a thunderstorm going on outside, so it's affecting the Wi-Fi. But if I thought I heard you said, Dr. Sanders, that you wanted me to identify some things on my side of the coin in the plumbing and the heart that will cause that are.
Uh-oh, he's going in and out.
He is.
So it looks like we're going to have to come back to.
Yeah, I'm the one going in and out.
Yeah.
Go ahead, Dr. Green. Oh,
I think
there he goes again. Yeah, he froze again. Hopefully that storm will calm down. So I'm going to transition to another question. So someone has a stroke. 911 is called. They get to the hospital. What happens at that point? I mean, what's that team going to look like, and what should the family expect to start happening?
So, our treatment of acute stroke has evolved over time. And sometimes in certain areas of the city, that treatment team can come to your house. So, they have mobile stroke units now. I know University of Florida has been piloting a mobile stroke unit where they have a CAT scan in the
Rescue.
van or in the
The
mobile
vehicle,
unit.
whatever.
The
Yeah,
vehicle, that is. I might be having a stroke, so I'm gonna sit down and I'll see what happens. But sometimes that unit can come to your house because what's the issue? Time is brain. So the faster that you get evaluated, the faster a treatment can happen to help you potentially reverse some of the symptoms and signs of the stroke. And so if that mobile unit is not available, if you make it to the hospital within 3.5 hours, then the medical team will evaluate you. They'll do a CAT scan. The CAT scan will show whether or not it's a blockage type of stroke or a bleeding type of stroke. Because if you have a bleeding type of stroke, your treatment is much different than if you have a potential blockage type of stroke. And so they'll want to monitor your blood pressure and your vitals. And then if they feel that you are a candidate for what we like to call a clot busting drug, then they will give it to you through a vein in your arm. And that will hopefully help to thin the blood enough out to break apart the clot that's felt to be in the blood vessel. Sometimes other interventions can happen as well, but it depends on how your stroke mechanism is and what they find in their studies.
Thank you. Dr. Green, did you want, or Dr. Kane, did either of you want to add something?
No, I'm impressed that we have a van that goes around and
So am I.
people's house. I was not aware of that. I'm glad Dr. Sanders made us aware of that. But
Yeah.
what I can say is, Dr. Green, we can go back to your atrial fib as well, and now that you got a thunderstorm that has allowed you.
Yeah, well, atrial fibrillation. Yes, I'm sure you can hear me now. Atrial fibrillation, of course, is a very common cause of strokes, especially the embolic variety that Dr. Sanders had indicated before. Atrial fibrillation, of course, is by definition a very irregular heartbeat and very erratic. And what happens there is that there's a collection of small clots that form in the part of the heart called the appendage, the atrial appendage, which sits on the left side of the heart, which is on the blood supply of the heart that goes directly up to the brain. Atrial fibrillation increases with age. So the older you get, if you live long enough, you very well will wind up with atrial fibrillation. But prior to that, things like smoking and hypertension and all the other things that can cause a stroke that Dr. Sanders had indicated can lead to atrial fibrillation as well and increase the risks. And that's a 5-fold increased risk for a stroke once one develops that irregular, erratic heart rhythm that is called atrial fibrillation.
You know what, Doctor?
Like I'm seeing a lot more, and it could be, just because we gotten better at it, but it sure looks like I see a lot more AFib atrial fibrillation these days than what we used to. I mean, it just seems like one time it looked like every other patient was coming to my office was atrial fibrillation.
Yeah, well, that unfortunately that's true, and the incidence has gone up exponentially over the last decade and continues to rise as the population gets older. Number one, number two, the incidence of hypertension has also gone up. Number three, obesity is still a burden on the population from an epidemiologic standpoint, but to the extent that it will lead to a stress on the heart and causing atrial fibrillation. My patients always say to me, why would obesity cause a problem? And I say to them, look, if I put a 100-pound bag of cement on your back and ask you to walk around and up the stairs, your heart will just cry out and get miserable. And one of the ways that the heart expresses its miserableness is becoming very irritable. And most of my patients tend to understand that. It doesn't mean that there's something wrong with your heart, but if you put that stress on the heart with hypertension and obesity, then that can lead to atrial fibrillation. And of course, the 800-pound gorilla in the room, of course, is cigarette smoking. That too will lead to a narrowing in the blood vessels, which means that the size of the clot that can cause problems in the blood vessels also go down. So they're all interplay, and all of them are reversible. The only thing we can't reverse, of course, is age. All the other factors are reversible.
Do you see the strokes happening more in men versus women, or it doesn't really matter?
It can affect any sex, but we do tend to see more men with strokes, I think, because they are more likely to have some of those risk factors.
I think also because we're more hard-headed than women are. We don't tend to take care of ourselves as well. We don't tend to go to the doctor to do the preventive measures or find out what your numbers are. I mean, it's no secret to that one. That's been like that for years. Maybe I've seen a slight improvement in men in terms of them, taking better care of themselves, but we just don't do it. We don't go to the doctor. We don't go see what's wrong with us. We would rather sit around and play Superman for whatever reason, and then wind up being Superman in a casket.
I'm glad you mentioned it, Dr. Kane, because June is Men's Health Month, and it is a reminder for men to go in and get that exam. If you have not gone to the doctor lately, go in and get a checkup. Also, know your numbers, know what your blood pressure is, write it down. Every time you get it checked, put it in your phone if you are technologically savvy. Know your blood pressure, your cholesterol, your good and bad cholesterol. If you don't understand that, then ask your doctor to explain it. And sometimes I know Dr. Kane is very good about giving analogies. Sometimes he's going to explain it to you. He's like, okay, doc, I got it. But, he's really good about giving analogies to help folks really understand what's going on with their bodies, right? So when we talk about
Dr. Green was about to say something a few minutes ago.
That was a very important point you raised about taking the blood pressure. I seldom treat blood pressures in the office as a blood pressure. We get blood pressures in the office because it gives you some contact with the patient. You touch them, you feel them, you feel as though they're getting care. But I seldom use that blood pressure in the office as a tool to help me out. Now, of course, if the blood pressure in the office is 210 or 110 or some ridiculous number, then of course there's hypertension. But I bear in mind the fact that patients coming to the hospital can have something called white coat syndrome. Just thinking about the fact that you go into the doctor's office next day is enough to do it. That's a minority. But what I'm aiming at here is once I see that blood pressure in the office, the multiplicity of a multitude of patients that Dr. King would send to me, I give the patient, I'm a little old-fashioned still, unfortunately. I give them actually a sheet of paper, and I ask them to go out and get a good fitting cuff. And we have the MAs show them how to do their cuff, similar to the ones that we have, things that they can put on themselves, and have them record their blood pressures in the morning just before they take their blood pressure medicine, and 12 hours at night just before they go to bed, and try to get them into a ritual that allows them to buy into the fact that they're part of their process. The fancy term that we use is ambulatory blood pressure monitoring. And that is going to become a very important part of how we manage patients going forward, particularly from the insurance and the reimbursement standpoint. So ambulatory care management for hypertension and heart failure is the wave of the future. But the intent there is having the patient buy into the process of doing something to themselves every day, and not waiting until the day they come before they see me in the office and try to rush to take their medicines. But this is something that they are they're empowered. They have control over how they take their medicine and what results they're going to get, and it usually works.
Well, when it's a show and tell, when they can see what's going on, they're more likely to at least reach out to me first. Being a primary care, not just me because I'm a great person, but they tend to reach out to me, and I agree with Dr. Green. I give them a sheet. I want them to write it down because I want them to, instead of strolling through on the phone necessarily to look at it, I want them to be able to visually look right at it and see where their numbers are going. All the graphing and stuff, that's great if they can do it, but I want them to take a look at it, and we give them the parameters by which they should either become alarmed or at least where they need to get.
Imagine a song so powerful.
With me sooner or later, sooner than later, about issues they're having with their blood pressure and for observation. The one thing I will say about, I like to see those patients more frequently than, some people still have their patients come back once a year. I think that's asinine. But they give them some medicine and say come back later, and it's like, what about in the interim? So I usually see them pretty frequently until I know for sure the blood pressure is settled.
And I would like to kind of add on to that. And if it's been identified that you have high blood pressure and you're placed on medication, I want to stress the importance of adherence to that medication. I think we talked about it in the previous session, but there is no cure for high blood pressure. I'm not aware of any cures for high blood pressure. And when you're on a medication and your blood pressures, you're monitoring them and they look great, that is because you're taking the medication. And at any point you choose to stop or take breaks, then you're at risk for having your blood pressure shoot up really high. And when it comes to the brain knows how to function between a certain level of blood pressure. And if there is a quick rise in your blood pressure, oftentimes the brain does not know how to handle that. And you can have stroke-like symptoms, you can have confusion, you can have seizures, you can have headaches. And so that's because not that your blood pressure is extremely high, but it was a quick rise from where it's been. So it really is important that sticking to your medication, even if your blood pressures look normal.
And don't forget those making sure that we let patients know, because the first of that high blood pressure is pretty much painless. Because that's one of the first things they start saying. Well, I felt fine. I'm not hurting anywhere, so I didn't think I needed my medicine. I can tell when my blood pressure is up. I'm sure you guys have heard it. I can tell when my blood pressure is up. And then I know to take the medicine. And one last thing that they tend to do is they want to ask, well, Dr. King, and you guys elaborated on it earlier. My medicine is, my blood pressure is doing great. Can I stop my medicine now? Can I not take it now? It's like, why do you think it's doing great? And they said, well, you put me on the medicine, stop. I tell them, stop right there. I put you on the medicine, and that's why it's doing great. No, you cannot stop.
It's the annoying diuretic, Dr. Kane.
For some people, treating high blood pressure, we can talk about that at whatever point in time you want to. But, the diuretics are not the only thing that we rely on. And Dr. Green can tell you even better than I can about how he goes about determining which blood pressure medication to use.
Yes, well, treating blood pressure is a skill in itself. subjectively as described by Dr. Kane and Dr. Sanders, trying to get people to buy in. But then there's also the scientific component of it as well, where we know the variety of blood pressure medicines that will work. And each medicine, the diuretics, the beta blockers, the calcium channel blockers, the sympathetic system blockers, all of them come with the good resources, of course, but will also with side effects. And these side effects vary from person to person. So once we get started with the patient, we have to continue. I agree with Dr. Kane. You can't put a patient on or aim to treat a patient's blood pressure and see them once every year. It's just not going to work. I limit that within the first month. If I change a person's medicine, I would see them within a month after that. And of course, I will put a month on the sheet, and they go out, and the medical assistant will look at them and say, "Yeah, right. Dr. Green wants to see you in a month. Where is he going to see you, in the parking lot?" But we squeeze them in, and we make an effort, because in a way, if patients realize that you're making that extra effort to see them, although you might be running late, but they know that you're squeezing them in, that subjectivity tends to work as well. But each patient will have a side effect. So I tell my patients, check for the side effects, and don't be bashful about it. I'm not going to scream at you. If you have a problem with the medicines, you let me know. But in African American patients and people of African descent, I should say, treating blood pressures is very challenging. And one of the things that I want the audience to realize, that you probably will never get away with taking only one medicine. It's almost certain that if you are from African descent and you have high blood pressure, which you will have by virtue of your genetics, you're probably going to need 1, 2, or 3 medicines to get things under control. That's just a reality. There's really not. I'm Dr. King, and Dr. Sanders, I'm sure they will agree with me. There are not very many African American people controlling their blood pressure with only one medicine.
Nope.
The reality.
So on that note,
a study was done to show, real quick, I'm going to say this. Study was done to show that average number of blood pressure medicines that most people of African descent are on is 3.4 meds. Okay. Now, I don't know how to get to the 0.4, but that's it. 3.4 meds.
And Dr. Green, can you also touch on the fact, again, it's Men's Health Month, and why do men sometimes, and are there any medications that could impede men's ability to perform, hint, hint, which is why they don't want to take the medication?
That is a very, very important question, and I'm glad that you brought it up. It's very important. And the 2 medicines that we run into difficulty with is the diuretics, but more importantly, the beta blockers. In African American men, 50%, easily, 1 in 2, 50% of African American men who go on a beta blocker will have problems with libido and other sexually related problems. And the interesting thing is that I find that men, even talking to me as a man, if they even see me in the office by themselves, they will never, they're loath to admit that they are having problems. And that is something that I try to, so I don't even waste time about it. If I put a patient, Caucasian patients as well, but more regularly, the African American male, and you put him on a beta blocker, and his libido goes down, he ain't gonna take his medicine.
Right. That's why I mentioned it.
Right. And now it takes a little bit of skill to get that. First, you got to win their hearts. You got to let them feel that you really care about it. It's something that you feel comfortable talking about, and then you shepherd them through it. To the extent that you might say, you know what, we got a choice. Look, this is not quite working out for you. You're watching too much football. You're watching too much soccer. You're watching too much baseball. Let's see if we can get you a little bit more engaged. And they would say to me, well, can I get a Viagra? And I would say to them, well, Viagra is really not my favorite drug. And I want to hit on it, especially in this talk. I would rather use the Tadalafil, which is called Cialis. So the orange pill rather than the purple pill. primarily by
Blue
virtue
pill.
of the way it acts.
The blue pill. The blue
The
pill.
blue pill. The blue pill. Yeah. So
They may turn purple on it, but it's the blue pill.
the blue pill. But it is something that we need to. I face it up front. It is not unusual if the spouse is in the room that they would raise the issue as opposed to the man himself. Not unusual at all. And it takes a certain amount of skill and camaraderie to nurse that out of the. And there's different ways of doing it depending on the ambience you feel from the patients, you know. But it's something that is very important. So my one statement to men out there, all men out there, if you're on your blood pressure medicines and you are having issues with your sexuality, it is something that you should confront up front, because there are alternative medicines that can be used. Two, there are other medicines that we can use to help with any form of sexual dysfunction. And three, just talking about it alone decreases that stress level that is very much part of the conversation. And if you have that in the back of your head and it is not addressed, it just becomes more of a problem.
Let me say this real quick. What I will say to some of the men when they come in and said, "Doc, you put me on this medicine, won't it affect my performance?" I say, well, if you have a stroke, you permanently, it may affect your performance permanently. We got medicines to fix if the medication causes it. I got some other medicine to fix it. So that's usually how I win them over in terms of going on ahead and getting on the blood pressure medicine.
That's so interesting, though, because as ladies, I'm sure Dr. Sanders can agree, we'll talk about anything at any time. We're not ashamed to bring things up. But I know my experience of having done the Man Up for Health for so many years, that it is hard to get men to talk about their health issues. However, I found over the years that they've trusted me. They start sharing more than I am really sometimes expecting to hear at that moment. We're going to pause just for a moment, and then we'll get back to the discussion. Each week we feature a history maker. And so Tyrone, our behind the scenes technology guru, he calls himself something else. I was trying to remember what it is, but he's going to do a wizard. That's right. Our technology wizard
too.
is going to show our history maker, and then we'll get back to the discussion on stroke recovery. Cue it away, Tyrone.
June 11th, 2024. Dr. Olajide Williams is a man on a mission. He is a board-certified neurologist. He is a tenured professor. But Dr. Williams is more than titles. He's a visionary. His weapon of choice? Hip-hop. His battlefield? The hearts and minds of underserved communities. Dr. Williams saw a problem. Health disparities plagued marginalized communities. He knew he had to act. But how could he bridge the gap? The answer came from an unlikely source, the rhythmic pulse of hip-hop. It was more than music. It was a language that resonated. It was a tool for change. Dr. Williams founded Hip Hop Public Health. This nonprofit organization is revolutionary. It uses music to educate. It empowers communities. It tackles health disparities head-on. Dr. Williams' work is a testament to the power of innovation. He's a doctor. He's an educator. He is a beacon of hope. He uses his platform to amplify the voices of the unheard. His work is saving lives. Dr. Olajide Williams is a man of science. He is a graduate of the University of Lagos College of Medicine. He is a respected neurologist. His journey is one of dedication. His path led him to Columbia University. At Columbia, he rose through the ranks. He became a professor. He became chief of staff of neurology. His commitment to his patients is unwavering. He understands the challenges they face. He sees the systemic barriers they encounter. Dr. Williams' experience fuels his passion. He sees firsthand the impact of health disparities. He witnesses the lack of access to quality health care. He knows something must change. He refuses to stand idly by. He chooses to be an agent of change. Dr. Williams' journey is a testament to his character. He is a doctor who cares. He is a leader who listens. He is a visionary who acts. Hip-hop. Public health is more than an organization. It's a movement. It's a force for good. It's the brainchild of Dr. Olajide Williams. It's a testament to the power of music. The organization's mission is clear: educate communities, empower individuals, combat health disparities. They use a unique approach. They combine science and art. The result? Engaging and effective health education. Hip Hop Public Health creates music videos. They develop comic books. They produce school curriculums, all centered around health, all infused with the rhythm of hip hop. Their work is impactful. They reach millions. They educate on critical health issues. They inspire change. They give a voice to the voiceless. Dr. Williams understands the power of connection. He knows that underserved communities often distrust traditional healthcare. He recognizes the historical context and sees the present-day disparities. Hip-hop public health bridges the gap. It uses a language communities understand, speaks to their experiences, and meets them where they are. It builds trust. The organization's impact is undeniable. They've created over a dozen albums, partnered with renowned artists, and reached millions of children. Dr. Williams' approach is revolutionary. He breaks down complex medical jargon, transforms it into digestible rhymes, and makes health information accessible. He empowers communities to take control of their health. Dr. Olajide Williams' work has not gone unnoticed. He's a recipient of numerous awards, each one a testament to his dedication and a recognition of his impact. He's been honored by the National Institutes of Health and recognized by the American Academy of Neurology. He's received accolades for his community engagement. Dr. Williams' work speaks for itself. His passion is contagious, his commitment is unwavering, and his impact is undeniable. He's a true leader in his field. Dr. Olajide Williams' journey is far from over. He continues to inspire, educate, and empower. His work is more important than ever as health disparities persist and underserved communities still face barriers. But Dr. Williams provides hope. He offers a path forward using music as his tool. Dr. Williams is a beacon of light, a testament to the power of innovation, and a voice for the voiceless. He's a true history maker. His work will continue to impact generations to come. The beat goes on.
Wow, that was interesting. Tyrone, thank you, Technology Wizard, for bringing that to our attention. I want to now talk about, again, we talked about someone had a stroke, they're hospitalized. Who is the team of people that are preparing or treating that individual and preparing them to go home and be under the care of their loved ones, if that is the next step? Some people have to transition to a rehab facility. Can you talk about that some, Dr. Sanders?
Yes. Once we get past the first stage of the acute picture of a stroke, then comes the recovery, and that starts in the hospital. A person in the hospital will be treated by a multidisciplinary team. So this is a number of different disciplines that are there. It's going to include the neurologist. If there's any cardiac issues or concerns, it's going to include the cardiologist. But most importantly, it's going to include the rehab specialist. And that can be physical therapy. And physical therapy works primarily with the lower legs and your ability to walk. And then there's going to be the occupational therapist. The occupational therapist is going to work primarily with the upper extremities or the arms. And then they also work to teach you how to redo your activities of daily living. So it's going to be the occupational therapist that's going to show you how to brush your teeth again, how to comb your hair, how to use the restroom. And then there's also going to be the speech therapist. The speech therapist is going to help you with your speech and talking, but also swallowing. So sometimes stroke can affect how your body is able to swallow and get things down your throat. So the speech therapist is going to work with that. In some cases, there may be psychological aspects of it as well. And so some people do not adjust well to a new change in their life. So sometimes the psychologist or the psychiatrist on board. So depending on what your needs are, your team can have multiple providers taking care of you.
Thank you. And then when the person comes home, or why do some people get to go home versus having to go into a short-term facility, rehab facility? Is it largely due to the severity of the stroke, or who is able to care for them when they get home, or both?
It is a combination. I think the driving factor is the severity of the stroke and what level of functioning that they have after the stroke. And so the more assistance you need, the more likely you might need to go to a short-term rehab or an acute rehab setting. Now, I will say that unfortunately, in our healthcare system, your health insurance can sometimes dictate where your disposition is leaving the hospital. And so, if you are uninsured or underinsured, sometimes those acute rehab hospitals and those short term rehab facilities aren't a financial option for you. And so that brings up another person that's on your team, the social worker. So when they are trying to determine where your next step is,
Yeah.
the physical therapists are going to determine what your physical needs are. And then the social worker is going to look and see what's financially available for you. Ideally, we want patients to have the best care, the most effective care. If it's the symptoms are severe, it could be inpatient. If they're moderate or mild, sometimes we can get away with home health for physical therapy, occupational therapy, and speech. And then, as you mentioned, Jocelyn, it depends on how much assistance is available at home, whether or not you have family there to help to kind of fill in the gap and take over some of the needs that you have.
One person that you didn't mention, a part of the multidisciplinary team, is the mental health aspect of, or the mental toll that it has on an individual when they've had a stroke. Do they get to see or is a psychologist or a psychiatrist ever a part of the team? Because, I know even I've known people who had a stroke and are a heart attack rather, and are so fearful of it happening again.
Yes, so it depends on the healthcare system and the location. That in our stroke orders, a stroke psychology or a psychology referral is part of that workflow. Having the virtual options has made it a lot easier for us to access resources like that. So sometimes if you went into a hospital that didn't have a psychologist in-house, you wouldn't be able to see it. But with the virtual reality that we live in now, it's a little bit easier. But yes, in our system, in the Baptist health system, that is part of our workflow or our orders that we have for every stroke patient.
Thank you.
Also, I'm gonna expand it a little bit, because when they do get home, you still have these caregivers that we have to also educate, and they will, as well as, like what Dr. Sandra said, the social worker is the person that's given the task of seeing what that patient may need, not just from the rehab center or being placed in a nursing home, but what they need at home. What equipment they may need depends on the level of the stroke, what equipment they may need. And then you have the caregiver down the road, particularly depending on how bad the stroke is, we really have to start trying to, I hate to say, treat the caregiver, not medically wise, but psychologically wise, Jocelyn, since you mentioned about mental health, because that's a big burden that they may have to take on
Mhm.
And, some people just, excuse the pun, have a stroke, taking care of people having a stroke.
Mhm.
It's just a lot of work for them
Mhm.
to when they get home. And particularly if it's the wife and that's all he or she has, but also it winds up being the kids,
Mhm.
depending on their age, how much work they have to do in terms of helping mom out. So, I look at both, at least from my perspective. I have to treat both the patient and particularly once the specialist like these two guys turn them back over to yours truly. I have to treat the patient and the family as to what's going on within that household, um, including FMLA papers. I mean, it's just all kinds of stuff that you have to do on this in the background that people don't realize. Especially in primary care, what we do in the background in terms of making some of these things happen.
So, what about stroke recovery? Is there anything that's revolutionary as far as treatment goes that can really help people get back to normal, if you will? Any new advances coming out or anything, just something exciting happening, Dr. Sanders or Dr. Green?
I think there's a lot of exciting things that are happening, and our ability to use technology and robotics to help aid in people with walking. So in people that have trouble with weakness in a leg after stroke, or they're not able to walk, sometimes our physical therapists can put on external robotic attachments that can help simulate the way people walk. And one of the main reasons for that is, and I think I may have mentioned it before, is the brain's plasticity. So the brain's ability after damage to attempt to repair itself. It can either do that with sprouting new nerve cells to make those connections, or rewiring things. And so the best way to do that is with rehab. And if a person can't move their legs, we have external things that can simulate that movement. So over time and eventually, maybe the individual's body can do it on its own as opposed to the external robotics. So there are a lot of fun
That's
things that
exciting.
they do.
Yeah,
Mhm.
that's exciting. I only thought about that with someone who may have had uh, a traumatic injury or something. Never thought about a stroke. Dr. Green, were you going to say something?
Yeah, what I would like to add at this point too is that once the patient gets home, one of the focus that we have is to prevent the next stroke.
Yeah.
So it means reinforcing with we call it medical reconciliation, but making sure that transition from hospital to home, or hospital to the assisted living, or wherever they go, that whole list of medicines that they are on, the fidelity of that remains intact, and that's a challenge. That is so much of a challenge now that it is one of the benchmarks now for the I think it is the ACA is actually paying attention to medication reconciliation. It's not as easy as it sounds. But when patients go home and they have this sheet of paper with a list of medicines on it, that's a real that is a real weak point in the care of these patients. Do they go home on the same medicines? If we change the medicines, is that reconciled? Does the family know it? And on and on. But the new advances that we have, particularly in the kind of stroke that I deal with in my practice, from the embolism, from atrial fibrillation, is that thing called blood thinners. In the old days, we had was basically something called Coumadin or warfarin, which, to all intents and purposes, is rat poison. But it is all we had, and it was not as scientific. There were a lot of barriers. You had to get stuck every day. You have to know, you have to watch the kind of foods that you eat, and then when it levels off, you'll be at the doctor getting the finger stick every week or every month. It was burdensome. And so one of the new things that have come to our arena is so-called newer drugs that allow us to thin out the blood. We call it anticoagulation, so that we prevent that next stroke from happening. So those new drugs are available without even missing a beat. I can say that they're expensive. When they first came out, the insurance companies were very resistant to having patients on these medicines fall in love with the fact that they don't have to worry about getting finger sticks, going to the doctor, buying another equipment, something else to do, and in a world that is relatively imperfect. So these newer medicines that most people would know about, the Eliquises and the Xareltos and the Pradaxa. Those are the three common ones. The commonest one is probably Eliquis and Xarelto.
The one thing I will say with
medicines that about. Go ahead.
I was going to say, one thing I will say, I'm happy not to have to deal with warfarin as much anymore. Is that, like what you're saying, you got to take all these levels to monitor them. But, there's such a thing as over-treatment with that warfarin, and they bleed out and have another stroke, a different kind of stroke. They go from having the obstructive stroke or ischemic stroke and go to the hemorrhagic stroke. And so, and not everybody knows how to make those adjustments when it comes down to that warfarin. One question I did want to ask, and
Dr. Kane, Dr. Sanders.
Dr. Sanders, go ahead, Dr. Sanders.
No, I wanted to highlight because, Dr. Green, when he was talking about post-stroke care and the need for medication reconciliation, kind of brought to my mind really a study that I did when I was in my residency that looked at stroke education after an acute stroke with the patient and their family members, and whether or not they were able to retain the information that we are educating our patients after stroke. And I found that health literacy levels had a huge impact on how much a person and their family members retained, whether or not we were talking about the type of stroke they had, their post-stroke care, their medications, and the purposes for the medications. And in that study, we found that, as we have seen in other studies, is that people of color and lower socioeconomic status had lower health literacy, and they were actually retaining less information and that we were providing them, which is required by JCAHO. Every person that comes into a hospital with a stroke are required to get education. But I think what it brought and highlight is that education is retained very poorly immediately and will probably require additional education and should be occurring in follow-up, not just with the neurologist, but with your primary care doctor, because oftentimes they're going to see you, Dr. Kane, before they see me. And what we really should be doing is extending that multidisciplinary clinic team to the outpatient and including the primary care to continue that stroke education and that medication reconciliation.
The one thing I will say is that I make the patients bring in all the medications that they have at home, because they still may have some of the residual medications that they had prior to the stroke that has been discontinued, but you'd be surprised how many may go back home and restart the old medication, okay? Either not do the new medication or in addition to the new medication, putting themselves at risk for even an additional aspect of stroke, which is the blood pressure gets too low and they have a stroke on top of the stroke. One thing I didn't mention, and because I see we're getting close to the end, and is dementia associated with the stroke. Since you mentioned mental health, Ms. Turner, there are some patients that have that residual dementia, memory loss. You know, I'm not, and there are some things that happen with people that, you know, vascular dementia that we talk about. You know, and that's for another talk. But it crosses overlap with this discussion in that when these people, particularly with that, well, either one of them, hemorrhagic or ischemic stroke, depending where it occurs, memory loss may be a significant issue.
And mood disorders too.
Mood disorders, yeah.
Many times people who have strokes on the left side of their brain, they're at higher risk for depression and anxiety.
Right.
If they have frontal lobe strokes, they're at risk for having other behavioral issues. And so it is a physiologic part of stroke. And as you mentioned, Dr. Kane, that when someone has multiple strokes back to back or over time, it disrupts how the brain communicates, and it impacts memory.
Quite a task.
Well, we're at the end of the show. This went fairly quickly. Great discussion, though. I hope for people who've been listening that they really learned a lot. You all did a fantastic job of breaking it down and explaining to people and just giving people food for thought. As we wrap up the discussion about stroke recovery, I would like to give each of you an opportunity to just share your final thoughts or give your final little nuggets to our viewers. I'm going to start with you, Dr. Sanders.
My final nugget or takeaway is really advocacy, and that's advocating for yourself and your family members. I want advocating for acute stroke care, the appropriate multidisciplinary care within the hospital post-acute stroke, and then advocating for the most appropriate and effective rehab that is available to you. And sometimes the first time you hear no, that may not be the final answer. Just ask respectfully, is this the most effective rehab potential that we have for my loved one or for myself? Because sometimes people go the route of least resistance. And so you want to advocate for yourself and your loved ones.
And we'll put your contact information, but you are with Baptist Health, Dr. Sanders?
Yes, I'm an outpatient neurologist with Baptist in neurology in Jacksonville Beach, Florida.
Thank you. Great. Thank you. Dr. Green, what are your final thoughts?
What Dr. Sanders just said is so powerful that I'm gonna actually echo it. Advocacy, advocacy, advocacy. It is so important because it is one of the times that the individual patient loses that individuality. They need the help and the resources of family members and loved ones, church, any support group that they can have. But advocacy, understanding that the complexities of the management is very important. I think that's a very powerful point, Dr. Sanders, and thanks for raising it.
Thank you, Dr. Green, and thank you both for coming on. And Dr. Green, who are you with? What's your practice name? We're going to put it down.
Yeah, we're Baker Gilmore Cardiovascular Institute. We are on University Boulevard across from Memorial Hospital. We are a general cardiology practice group across the board. We are 4 partners, and we see all cardiovascular care.
Fantastic. Thank you. Thank you both. Dr. Kane, what are your final thoughts regarding tonight's topic?
Even tonight, I'm going to be somewhat redundant, and that is advocacy, advocacy, advocacy. I need, sometimes I need those family members to come with those patients to help me try to figure out what is going on at home, especially. And then sometimes what happened in the hospital, because sometimes we're not as quick to get those medical records from the hospital like we would like to, particularly if it's a hospital I'm not part of, and you have to, get it from whatever resources are available. And so it may not be there for me when I'm seeing the patient, but then I need to be able to put someone in the household responsible for contacting our office or staying in contact with our office so we can see what's going on with that patient. Maybe not on a daily basis, but on a
general concept,
definitely on a weekly basis, if nothing else.
Thank you, doctors, Dr. Kane, Dr. Green, Dr. Sanders. Yesterday, when I got off work, it was very hot, but I made the decision that no matter what, I'm going to get out and exercise because I thought about the conversation that we were having today. It is important, no matter what the doctors can do for you, we have to start with ourself. Self-care is so important. As was said often tonight, make sure you take the prescribed medicine that was given to you, not someone else's medicine. Take your medicine. If you're having a hard time affording to take the medicine, talk to your doctor. Pharmaceutical companies sometimes will offer some assistance for patients who are having a difficult time. Also, there are federally qualified health centers that you may need to access and start to go to for your care as another option if you are underinsured. Make sure that you're eating right. As mentioned, we talked about it before. The foods that we should all eat don't come with labels. We know what those are: fresh vegetables and fruits. And despite what people say, you do need more than one serving a day. You need a combination of at least 9 servings a day, some will say. And an easy way to do that, 5 vegetables and 4 fruits, or you alternate each day. Maintain your stress level. Make sure that you take some time for yourself to relax, turn off the television, put down the phone, just meditate and relax. Thank you to our listeners. And also, don't smoke. If you need assistance stopping to quit smoking, make sure that you do that as well, because unfortunately, smoking causes so many health issues. One thing that we cannot do about, 2 things rather, we can't do anything about is who our parents are. So as far as our gender goes, and as far as our race is. But for those things that we can do something about, become knowledgeable about the issues that the health conditions that we bring here at Pause for the Truth. Make sure you have a primary care physician that you're going to on a regular basis to help you manage your health care. And tune in each week to Pause for the Truth. And don't forget to subscribe to our YouTube channel and share. Tell your friends and family. This is an excellent program. Doctors Green and Sanders explain things to us so easily, or so simple, but so important. Thank you and good evening.
Night.
And there we have it, another episode of the Pause for the Truth podcast in the proverbial books. Our heartfelt thanks go out to every one of you who took the time to tune in. Mark your calendars, we're here every Tuesday at 6:30 Eastern Standard Time. Feel free to join our community on Facebook, Twitter, and LinkedIn. But the golden ticket? Subscribing to our YouTube channel. That's your passport to all our latest episodes and exclusive content. A special mention to the wizard behind the curtain, Tyrone Jackson from Call Tyrone IT Services. His technical prowess and unwavering dedication are the backbone of this podcast. Next week, we'll be back with more. Until then, tell your friends, tell your family about our show. Your support is invaluable. And remember, keep that